Yeah, I'm the Forensic Medical Review at Temple. I'm also in the Army. I'm the 8th year right now. And then also I'm from Boston. And then I went to undergrad at Penn State. And I was serving as the president of our school last year and this year as well. And then I'm about to go residency soon next year. And that's why.
Yeah, so thanks so much for coming. Yeah, so we appreciate AJ's doing this for us. And so he's going to talk first, and then, like I said, you're going to get a chance to practice on each other. I would say let's go ahead and we'll catch up our
other
person.
It's a pleasure and honor to be here. I'm so happy to be here today to talk about the diabetes and neuropathy along with the monofilament testing. And then first I'm going to start with the outlines. So I'm going to talk about the what's peripheral neuropathy, what causes peripheral neuropathy, what are the types. And then I'm going to talk about the origin of the monofilament test and then how to conduct them with the, I guess you guys have a 10 gram of monofilaments, which is 5.07, and then 10 side and then also going to talk about are we solely using the monofilament for peripheral neuropathy and also the recommendation of the diabetic screening based on the American Diabetic Association. I'm going to finish with the conclusion. Can you guys hear me?
A little louder.
Louder,
I can't hear. I'm old. I'm deaf.
Oh, sorry. Yeah. So basically, peripheral neuropathy is simply the unpleasant sensation caused by the lesion and disease of the somatosensory nervous system. So simply like the damaging the nerve. As you guys see in the picture on the left, that healthy and unhealthy. Like some of the medical students probably know, like the myelin sheath that it helped the conduction of the conduction, which the unhealthy has some of the degeneration of the myelin sheaths. I just want to point out there for the medical student. And then, so what are the causes of the peripheral neuropathy? So the most common one is diabetes, but it could also be caused by chemotherapy, also the alcohol, drinking, any trauma, or the postherpetic neuralgia, which is caused by the via sexual the contact, and those are causing the peripheral neuropathy. And then, so what are the types of the diabetic peripheral neuropathy? So there's a different types. Small, large fiber neuropathy, which is like you'll feel the numbness, tingling, and small fiber neuropathy is burning sensation. The autoimmune neuropathy is like you'll probably see the patient with the dry skin, like xerosis, and then those are the common presentation of different types of neuropathy, as you guys see on the right, the pictures. And then, so where's the origin of the monofilament test? They start with the, you guys see it? Okay. So they start with the finding diagnosed the sensory loss of leprosy patients. So leprosy is basically caused by the slow bacteria, which is known as the Mycobacterium leper, which is causing the skin, nerve, and other organs. And then we use the monofilament test for that, and then to find out the loss of pressure sensation, which because it automatically leads to the subsequent ulceration. That's why the monofilament test detect the loss of those pressures. And then, so why do we even care about the monofilament test? Because we want to find out the loss of protected sensation. And then if we don't find out the loss of protected sensation, it could lead to the callus, which because of the pressure, as you see on the second picture, and then the callus could lead to the ulcer, infections, and even with amputation. So we want to prevent that amputation, ulcer, and the calluses, so that's why it's really important for us to conduct the monofilament test. At the clinic at FAI, Clinical Clinic, we always check the monofilament test to find the any loss of protected sensation. And then, so how do we conduct the monofilament test? So basically, you let the patient to relax, quiet setting, and then you don't want them to see that you're where you're pointing at, and also you want to initially start with the inner wrist because you want to show them how do you feel with the monofilaments, and then you apply the sufficient forces to cause the filament to bend or buckle. And then, so basically each point is 2 seconds, and then do not apply on ulcer, callus, or necrotic tissues, and also make sure that it bends not to slide. And then you want to kind of randomize the point, because sometimes the patient are memorizing that pattern, which is like, they probably say, yeah, like you don't want them to memorize the pattern, so you kind of switch around the 10 points, and then make sure that you apply those 10 points as well. Yeah.
What does it mean by repetitive contact when it says?
So repetitive contact means that sometimes when you use a monofilament test, and then you don't want to place it twice.
Oh,
okay. So after the 10 point, you can go back and test it, but don't place it twice, because
Don't
obviously
tap
the
it.
patient won't feel it. Yeah. So
Tap it.
yeah. And then so the 10 points are those. On the dorsum aspect, there's 9 points on the plantar aspect, the bottom of the foot, and then on the bottom, 3 tips, first, third, fifth. We call it as the submed head, which is the on the forefoot, 4, 5, 6, midfoot, 7, 8, and then hindfoot, 9. And then 7 out of 10 is normal. If it's less than 7 out of 10, it's abnormal. Any questions? No questions? So based on the American Diabetic Association guidance, that we always do this, like after patients, after the diabetic patient came in, we always which criteria that patient belongs to, because we want to see them, like, if the patient shows there's no loss of protect sensation or peripheral vascular disease, we want to see them annually, every year. And if they have a loss of protect sensation with or without deformity, deformity means like the calluses, and then we want to see that every 3 to 6 months. And then loss of protect sensation without the peripheral vascular disease. So peripheral vascular disease is basically that you guys think about the pipeline, and then some kind of dirts are accumulating at the pipeline. It's causing the burning sensation at the digits, and that's called the peripheral vascular disease. And then we want to see them every 2-3 months, and also we've got to think about the vascular consult for us. And then if they have any prior history of amputation, ulcer, if they have the end-stage renal failure, we want to see the patient every 1 or 2 months. And based on the Medicare, Medicaid guidance, it's every 9 weeks, which is
And then can I just explain, LOPS, loss of protective sensation, and PVD, peripheral vascular disease, sorry.
Sorry.
Yeah.
Use that. Yep. Any questions? Question? I'm sweating. It's hot in here.
Loss of protective
Loss
sensation.
of protect sensation. Yeah.
We can turn the AC on, except it's loud.
Yeah, it's a
We'll do
Okay,
it during
so
the
yeah,
practice
for
session.
every patient, I always counsel them, make sure that you inspect your feet daily basis, because if diabetic patients, sometimes if they suffer from the diabetic peripheral neuropathy, they don't feel anything. So that sometimes they if their needles are stuck in their foot, they don't really even realize. And that's really critical thing, because it could lead to infection, ulcer, amputation. So we want to avoid that. That's why we're telling patients to make sure that they inspect their feet daily basis. Do not walk on the barefoot. You want to keep it moisturized, because dry skin, I was talking about dry skin, right? Dry skin, if it's leading to a fissure means like an extended version of dry skin, that could create a portal for infection. So that's why you want to make sure that keep it clean and moisturized. And then wear the white socks. Why? Because if they bleed, they can easily notice, because sometimes they don't feel anything. If they visually notice, they can either go ER or see us, and then we can treat it from there. And then no prolonged soaking. So based on the article, that if you soak too long, and it could lead to the infection as well if it's too prolonged soaking. And also make sure that it's important for us every time we always ask what's your glucose level, what's your A1C level. So A1C level is basically the 3 months of worth of the blood glucose level. We always ask them. And then always exercise, because a lot of diabetic patients we see they tend to be morbidly obese. So we always exercise. And then make sure that you ensure Medicaid compliance. Make sure that they take metformin. Metformin is the typical meds for diabetic patients, and then routine foot screening, as I showed previous slide, that how many months that should follow with the podiatrist. And also of the patient with the neuropathic pain, they should take gabapentin, Lyrica, or TCA, which is a tricycline antidepressant. And also like the new med, which is the podiatry, which is the vitamin B12 as well. And then those are the counseling that we do at the clinic. And then it's okay to forget everything. So the 3 points, I just want to give you 3 points, which is the, so peripheral neuropathy, as I was telling you about, they will tend to show numbness, tingling, which is, as I said, large fiber neuropathy, and then burning sensations. And then make sure that for 10 points, if they, you want to make sure normal is 7 out of 10. If you see less than 7 out of 10, that's abnormal. And then also make sure that you understand about the recommendations from the diabetic screening that I showed two slides before. And do you guys have any questions for me? Yeah.
So for diabetics, it's important to exercise to control blood glucose levels. But if they have neuropathy, how does that affect their exercise because they can't feel their feet? Like, does that make it harder, or is
So like the purpose is the so we cannot fix the peripheral neuropathy, but the peripheral neuropathy is causing due to diabetes. If we treat the diabetes, we can slow down the progression of the peripheral neuropathy, which because of the diabetes, which is glycation, which is your body just can't take glucose. If you exercise and then we can kind of slow down control the glucose and A1C, that could less progression of the peripheral neuropathy. That's why we always recommend patients to lose your weight and exercise, and then try to modify your nutrition aspect as well. Because like as a physicians, we're not here to fix them. We're here to educate them, and also that let the body heal by itself. Like, so for me, like we as a podiatric surgeon, we do surgery, right? We do like bone fracture, we reduce them, but we're not fix them. We put the body in the right position for the body to fix it by itself. So that's why we always ask them. Hopefully I answer your question. Yeah. Any questions? Yes.
This may be a general question that you can answer as well. Is with a lot of diabetics who like exceed like their full-blown diabetics who need insulin, how accessible is insulin in these communities?
It actually, believe it or not, it is pretty accessible because in general, if you can get Medicare or Medicaid, then you get it covered in a decent way. Now, learning how to use it, having the ability to get to an appointment to see the doctor to get trained and how to use it correctly and keep your blood sugar under control, that can be a little bit harder when life is a bit more of a struggle. But to get the actual medication is not as hard. Now, we do have a reasonable number of people who are either illegal or underinsured for whatever reasons. That's harder. But they're a smaller subset of the population.
That's me, but I'm not.
Is foot neuropathy more common in like type 1 versus type 2 diabetes?
So I mean, to be honest, I think it could cause both.
Yeah, both can cause
Yeah, both can cause it, because just really diabetes, that glycosylation, which is causing the myelin sheet to degenerate, and then you really don't feel anything. But it's a really slow progression that sometimes that I actually saw the peripheral neuropathy yesterday. Their complaint is numbness, tingling, and then numbness, tingling, and they don't feel anything. Like I do the monofilament, and also I do utilize the other modality, which is the tuning fork, and then I kind of
So the thought, I think, is for insulin dependent, it can get a little bit harder to control their diabetes. With type 2, the swings are usually not quite as broad, and there's a lot more in the armamentarium to keep that from progressing. So, you know, there's that. But either one can cause
Yeah.
peripheral.
I see so many diabetes sometimes I.